I would say let's go.
Sure. Well, thank you again for the invitation. I'm delighted I'm always delighted to talk about EPAs. So I'd like to take you for about half an hour, I think, through some fundamentals of untrustable professional activities and entrustment decision making. My name is Olle and Cate. I'm from the Center of Research and Development of Education. And just to add to what Roel just said, I recently stepped down as the director, but I'm still a senior scientist at the center. And that's located at University Medical Centre Utrecht in the Netherlands. Now I see I have to move my slides. Yes. So I will be talking to you about competency-based medical education, about its purpose and its practice, about the inherent difficulties of workplace-based assessment that we all face in clinical education. Then talk about EPAs, what are EPAs and why may they be a solution to our inherent problems of difficulties of workplace-based assessment. Talk a little more about the nature of EPAs and the levels of supervision. A little bit about prospective rating, I'll explain that word, and the qualities that affect entrustment decisions. And I'll end with a small wrap-up. My focus will be largely on medical training, but you can just translate that to any health professions type of education, and also to maybe even to other domains. So let's start thinking about what is the ultimate goal of medical training. And you could phrase that as expecting that physicians and residents and specialists that we graduate can be trusted to provide high quality and safe care. And that is something that sounds easy, but it's not so easy actually. Who can be trusted to do what? Let's turn to something that is linked to the idea of entrustment as the level of supervision that you need. Now, if you would look at what the Netherlands say in their medical act, their legislation, so the Dutch Medical Act actually says that all doctors are entitled to perform medical tasks. All those who have an MD degree and are licensed and took the oath are actually entitled to perform medical tasks in their breath. But in practice, they will not be allowed to do that because what is added is provided that they are competent. So what does that mean? What is competence? That's the big question then. What is competent and how do we know that people are competent? Just imagine you are a program director and you are at the point of graduating one or more trainees at the end of specialty training. An important question that you could ask yourself is, would you trust your own family members as patients for those who you are graduating? We're actually doing a study at this moment, and we recently published some of that in the British Journal of Anesthesia, that we found in interview studies that many residency program directors can recollect cases signing off themselves for completion of training, even if they were not confident about the level of their trainee at graduation. So why is that? Why do people have difficulty do that? Why does it happen? You can call that failure to fail. So it is you cannot easily stop students sometimes, because one of the reasons could be just the time is up. You have a 4-year program or a 5-year program, 6-year program, and it's just at the end of the program. I mean, it's July 1 or any other date in the year, and that's the time to graduate. So you're graduating people even though you sometimes may not be confident. Or you would say, we don't have any valid documentation to back up any failure. We know that people don't meet the bar, but we just can't, we don't have the evidence to show that. And if they would make a case against us, they would probably win. Or you would say, well, if you would fail a trainee, that would give yourself trouble, because there's a whole hassle going on if you would fail a trainee. So rather not do that. Or you could say that we don't just have the tools to handle this. Or some people would say when we are unsure, we probably rather err at the benefit of the trainee. So give him the benefit of the doubt. But at the same time, you have to realize you're not giving the benefit of the doubt for the patient. So you could say the imperative of competency-based medical education is to reduce false positive decisions when graduating trainees for unsupervised practice. Competency-based medical education was first described in 1978 in a document was written for the WHO. And for some decades, you didn't hear much about competency-based medical education until about the turn of the millennium, when the Canadians presented their CanMeds framework and the United States came with their Accreditation Council for Graduate Medical Education Outcome Project, and the United Kingdom came with Tomorrow's Doctors. So why was that? There was a general dissatisfaction felt with the quality of care in hospitals. Patient safety was an issue, but also dissatisfaction with training models, with the supervision. There was not much structure in clinical training at all, actually, in the until the 1980s, 90s. So here's where they suddenly important documents were published and that were used in several countries. And those who are in different countries will recognize their own system. The Netherlands has adopted the CanMeds model. Now, the essence of competency-based medical education is actually that education should aim at a standard level of proficiency for all the graduates. And critical features then are a clear description of those standards. So we want to know and want to define what is a good physician or a specialist. We need to assess all medical trainees using these standards, which actually means that if we acknowledge that trainers are not identical, that their competence should be actually the criterion and not the time in training as a primary reason to finalize training. Here's an example. Look at these data. These data are actually from a progress test that is being taken among the Dutch radiology residents. And these data are across a number of years and across also different stages of training, from postgraduate year 1 to postgraduate year 5. And you could actually see that people actually increase. It's a comprehensive test across all of radiology, and every resident should actually, it's a mandatory test. They all take that test. But what not was until recently, what the radiologists did not do is set a bar that everybody would have to pass the test. Now they did that. They now say we are moving to competency-based medical education. So what we are defining, this is the minimum level that every resident should pass. And it's not a very high level. It's really doable for all residents, but it's critical specifically for this group. This is a group at risk. We no longer accept these people to graduate in radiology because they have not met that threshold level that we would call for a competent physician. So competency-based medical education has the principles and has practice. And principles are embraced in many countries. People like this principle and say, well, this is the direction we should move to. In practice, there is sometimes some criticism. I can show what happens if you move to competency-based education and are very elaborate in describing the competencies. Here's an example. The CanMeds model has seen many generations. The most recent generation is about 5 years old, and now has very elaborate descriptions. It has 7 roles, and 7 roles is something that people be able to remember and can think of when you evaluate trainees. But there's also many key concepts, many key competencies, enabling competencies, milestones, many things. And it's not easy to use all those elements. Even if you would only have the 7 roles, just imagine you are a clinical educator, clinical teacher, and you have an intern who does a rotation with your with your department. And the question is, please rate this intern at the end of your rotation on 7 domains of competence. Only 7 domains. We're not talking about 700 elements. And we have the same 10-point scale that was just mentioned in a previous presentation, from 1 to 10, and from extremely low to exceptionally high. Just imagine you are forced to give a score. And you just imagine it is very, very hard to get that score because there's so many things you don't know. You have only a limited view of this resident. So this, you can just imagine filling out forms that look like this is not going to be very reliable. And some years ago, Stefan Luhr and his colleagues published a paper in Academic Medicine. And what they concluded on the measurement of general competencies is that there's no evidence that the current measurement tools can assess competencies independently. So we need further efforts. Actually, they are even unlikely to be successful. So their advice is use competencies to guide and coordinate evaluation rather than develop instruments to measure competencies directly. Yet, measuring competencies is what most programs still continue to do. And you will encounter issues in workplace-based assessment doing that. There is, based on the literature, there is something like generosity error. People give too high scores on average, which also relates to the failure to fail phenomenon. Then there's a halo effect. You have only a very small observation, and you're tending to generalize from one observation to a whole holistic picture of the person. There's a lack of reliability. There's no reproducibility of scores across occasions or across raters. There's very often unclear standards, or very often people don't even have a standard in mind when they have to make a score. And we know that observers and raters differ in how they observe and they rate. And ratings are unclearly related to either proficiency. You could say, well, this trainee is a very good trainee, so proficiency is high, give high score. Or personal development, you would say, I see where they come from, so they develop so much they deserve a high score. Or to effort, you say this is not a terrific student, but I can see they have spent so much effort. I want to actually award them for the effort. Or you would say, well, this person is not perfect, but the reference group of other trainees have been scoring so highly, I can't stay behind for this one learner. So why is competence assessing competence so difficult in the workplace? Just imagine this. Imagine you are a clinical teacher. Your school and your educational program director asks you to observe a learner, to provide feedback, and to report a score for that student. Now, imagine, just close your eyes or open, keep open, whatever, and you are observing a student, and pause and analyze your own thinking. You will probably recollect cases that you find it not very easy. So I'll think along with you. So was the student prepared? Was the case easy or difficult? So what actually does a perfect task execution look like? Or maybe you found this performance pretty weak, but how can you say that to the student without hurting their feelings too much? And you have to realize tomorrow you'll have to work with that same student, so you won't interfere with your working relationship. And so what actually is a reasonable score on a 5-point scale for this pretty weak student? Would it be a 5 or a 6 or a 7? And since you have to work with that student tomorrow too, you'll like the student, and you maybe have been the only observer in this afternoon. Nobody actually knows what is going on in your mind. So maybe. Could you give a 7? Well, your heart actually says no, it should be a 5, but then that gives you difficult. Well, all these kinds of difficult psychological things go through your mind. So the psychology of traditional workplace-based assessment is pretty difficult. And you know the learner actually hopes to receive a superior mark. And in your mind, you're thinking, she is a nice person, she works hard, it will not hurt her, and it will probably motivate her if I mark her as superior. So we're not really satisfied with these processes. So what is needed? So we would actually like to have assessments that more matches clinicians thinking in clinical healthcare and training for entrustment with critical activities in healthcare. We'd like to preferably give a holistic and not a tick box approach. We'd like to have integration and not separation of various competencies. And at the same time, you want to do something that's practically feasible. Jim Crossley and his colleagues about 10 years ago published an important paper that was called Good Questions, Good Answers. So what you'd like to get, if you want reliable answers, you must align the construct of patient care with assessment. And that could make assessment skills more reliable. This is an example of such an approach. Just imagine you are a clinical teacher in an anesthesia department, and you are looking at residents and looking after residents. The single most important question that you have every day is, can I leave the operation theater or can I not leave it? And if you use that in your assessment approach, it's not whether you're like the student or not like the student. Can you leave the operation theater? Is it safe to do that? Can you leave your resident alone with the surgeons and with the patient? Using that scale actually improves reliability of assessment. So it's a different approach, and it's a different approach that really links to entrustment. So entrustable professional activities, this is one of the reasons to start using that. And some, such as the surgeons and many other specialties, have found that the idea of entrustment and entrustable professional activities might be the way to go for the future. So to rehearse with you the definition of EPAs, an entrustable professional activity is a unit of professional practice. You can think of it as a task that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute the activity unsupervised. The purpose using EPAs is to operationalize competency-based medical education through a stepwise and safe engagement of trainees in clinical practice with a progressive autonomy. And to become competent can be defined as passing a threshold that allows for sufficient trust in the trainee to act unsupervised. So why would we use EPAs? So we have that threshold, and that's the MD license for specialty registration, but it's far too broad. We cannot oversee that. For any single educator cannot oversee that. And EPAs break that down into its breadth breaks down in units of practice that can be overseen, assessed, monitored, documented, and certified. It could be like 14 EPAs for dentistry, for instance. It's a reasonable number. Competencies are often felt too remote from clinical duties to be optimal for assessments. They are very often felt as rather theoretical. And EPAs is just the work that must be done tomorrow or the day after tomorrow. That is something that you can assign to someone, and they are a better focus for assessment. A regular assessment is not directly linked to the progression of responsibility. You give a score and then everything is the same still afterwards. Entrustment decisions, however, for EPAs are deliberately linked to progression of responsibility. So entrustable again is acts that requires trust, and could be by colleagues, by a program director, by a clinical teacher, by patients, by the public in general. It is professional. An EPA would only be an EPA if it's confined to an occupation with an extraordinary qualification and right. So you're bestowing that right on an individual because they have shown that they can do that. And it's an activity. It's not a competency. It's an activity. It's a task that must be done. But EPAs can ground competencies in daily practice. So again, if you look at the difference between competencies and EPAs, competencies are clearly person descriptors. They describe a person in their knowledge, their skills, their attitudes, their values, their abilities, their scholarly skills, whatever. So a competency, if you look at Oxford Dictionary, is the ability to do something successfully or efficiently. And EPAs, however, are work descriptors. They're outside the person. They're not part of the person. They don't describe any person. They describe the work. They're essential units of practice. A patient must be discharged, must be counseled, family leading must be led, a treatment plan must be designed, patient must be resuscitated. So if you have a competency is the ability to do something, that's the EPA. It is just something that is trusted to be done successfully or efficiently. So if you have a clinical department, there's many tasks that must be done, and you want to assign them to people that actually can do that or have the right profile to do that. If you don't have those persons, you have to hire them or see that you have the persons available, or maybe train them to have the right profile. If you have a surge of COVID-19 in your ICUs, you're looking around to have the people with the best profile to help you, or you have to train them and instruct them, get them an EPA in attending patients with COVID-19 on the ICU. So if you look at EPAs and competencies again, it's 2 dimensions of a grid. But there's hardly any EPA, any task in healthcare that you can imagine that does not draw on several competencies domains at one time. Even history taking, you say, well, you need communication skills, of course. But if you have no idea of professionalism or no idea of health advocacy or specifically medical expertise, you may not be able to ask the next question because your clinical reasoning is dominant in your history taking. So, and that holds for any EPA you can think of in healthcare. So if you assess learners, please assess them based on EPAs. That are the things that they, at the end of the day, you must graduate people because they can do the work. And whether they have the competencies, that's fine to know. But you actually, if they satisfactorily can do all those EPAs, you can just infer that they will have those competencies. So in that sense, working with EPAs is actually building a holistic framework because all those competencies, competency domains actually are integrated in the evaluation of an EPA. So why do EPAs then change workplace-based assessment? The core question of assessment for entrustment is not so much to determine the point on a scale of proficiency that matches the learner best, which is the traditional approach to assessment. But here it is considering a decision to increase the autonomy of the learner. So if we would go back and define competent, you could actually define that very easily by saying that when a professional activity is mastered at a threshold level that permits trust to act unsupervised. So competent then is a stage in a developmental continuum. And that continuum could look like this. There's growth of competence. If you superimpose that on a framework of development, and this is a well-known framework that was published about 30 years ago by Dreyfus, and they distinguish 5 stages of development, which is novice, advanced, beginner, competent, being proficient, and being expert. And the nice thing is they use the word competent in the middle of their skill. And here's where we would define, after a training period, this person has passed a threshold of readiness for unsupervised practice, we trust that person to be ready to do that, and that could be defined as our training period for that EPA, for instance, because this graph could represent an EPA. Another EPA might be easier. Or another EPA, you started training only in the second year of training. This is a very easy EPA, but if you could draw that same line, that threshold of being competent, you could easily see that there could be different moments during the training period that you could actually make that decision, a justified and trustment decision that people can work on their own. They don't need supervision. That does not necessarily all happen on the last day of training. You could do that for some earlier. There could also be an EPA that you actually have established, that you know that people have passed a threshold level. But after training, if they never practice, they don't continue with deliberate professional practice, they will not increase, may even decrease in their competence. And if it's a very critical activity, maybe after a while, you should lose the trust of any educator, or maybe the trust of the public and the patients to do that EPA. So you should think of that too. So we've talked about supervised or unsupervised practice, but there is a more detailed scale. And we usually use 5 levels of supervision, reflecting an increasing trust in the level of the trainee's autonomy. So we start, of course, at allowing the learner to be present in the healthcare environment, but not permit them to enact an EPA. The second level would be to have them practice with direct proactive supervision of a supervisor in the room. The third level would be to practice that EPA with indirect supervision, reactive supervision, that the supervisor would not be in the room, but would be readily available if the learner needs help. It's a significant next step, because between 2 and 3, it's very important to understand that the learner will acknowledge that they actually need help and that they will actually do that. And level 4 then would pass that threshold for unsupervised practice. And if you're still in a training period, because you're formally still a trainee, of course there will be distant oversight and or supervision at a distance. But basically that's the level that you would expect people before they go to unsupervised practice. They have to have that level. And if you are even more proficient, you might act as a supervisor for more junior learners. So if you think of it, this could lead to an individualized workplace curriculum. Just imagine you have a learner with a portfolio, and the portfolio could look like this. You have 4 EPAs, there's 4 years in your postgraduate training, and that learner actually progresses for each EPAs through all those stages of 1, 2, 3, 4, 5. And you could easily see that level 4, which is actually the minimum benchmark level for completing the training, could be for different EPAs at different moments in time. And for some EPAs like EPA C, there could be an early one that you could start being a supervisor for junior learners. And just imagine this is an individual portfolio for trainee Jones. For another trainee, there might be a template of expectations that looks like this, but in practice, those decisions to have people do things on their own unsupervised, the decisions for level 4 could be at different moments. So that could be individualized. Now, an important way to think about this is the distinction between retrospective evaluation and prospective evaluation. All those people who are educators, and many of you, I hope who are listening, are educators. And basically in education, what we usually do is we give assignments to students. It could be preparing for a test that we take, or giving an assignment to do something in practice. And when the student actually does that assignment, they get a high mark. And you could say, well, if you have done all, show mastery, everything that we ask you to do, and mastered the content taught in courses and rotations, we'll sign you off at the end of training that you have passed all those hurdles to be graduating. Now that's a prospective perspective on assessment. Oh, that's a retrospective perspective. The prospective perspective is different. The prospective perspective asks the question, is this student ready to assume the expected future responsibility? So why is that a different question? The difference is because even in rotations, even if you have frequent observations, you are sure that you will not be able to observe everything that's necessary. And you are graduating people in healthcare to do things that you may not have been able to supervise. And even the trainee may not even have encountered. So if you go back to the psychology of EPA-based workplace assessment, you have the same student, please mark me as superior. So now your thinking is, if I mark her in an entrustment decision, you could think, well, she's nice and she works hard, but it may hurt my patients if I mark her ready for unsupervised practice. So that may withhold you to give a too high mark at a too early stage. So the trust concept in EPA-based assessment is really linked to this whole idea. So trusting someone is making yourself vulnerable. If you take that decision that the student is ready, you will transfer your own patients actually and give them in the hands of your learner. So you take a calculated risk that any adverse events are acceptable, can be solved if you need it. And graduates, you have to realize, will be certified to carry out activities that you have not, as a supervisor, ever been able to observe. And learners may have never even encountered those. It could be rare instances, but if you take that trust decision and entrustment decision, you actually take that decision, and that's looking prospectively. So that gives a different flavor to your whole assessment approach. So entrustment decisions require some sort of estimation of adaptive competence to cope with unfamiliar situations. And if you do that, trust can boost confidence and motivation. If you really say to someone, I'm not giving you a high score. I know learners who get a high score at the end of a rotation, and then they would say to me, I don't know whether I can trust that, because they do that with every student. But if you would hear a person say, well, now I'm ready to have my own family members, have you take care of those? That is really a true sign of confidence in you, and it can boost your self-confidence. Now, if we think of entrustment decisions, we should make that difference between ad hoc decisions and summative decisions. So ad hoc decisions are those decisions that you take every day as a clinician in daily practice. You will evaluate them. And after a while, if you've seen that enough, you would have persons actually go for a summative entrustment decision. That is more of a formal statement, a statement of awarded responsibility based on multiple workplace-based assessment and focus on increased autonomy. Sometimes we call that a STAR, that statement of awarded responsibility for a specific EPA. And the flow of workplace-based assessment data that you could use with a portfolio, it looks like that. Here is an EPA and a learner. There's multiple times that this EPA is being done by that learner, and every time there is an observation, the one who observes and preferably using mobile devices to actually efficiently do that, that evaluation is being done, and actually the result is actually transferred to a portfolio. And in the evaluation and feedback to the learner leads to a better performance the next time for that EPA. And if that EPA has done sufficiently and at a high level, the learner may be ready for a summative entrustment decision. So what happens then is either the learner requests that, or a supervisor might suggest that to a clinical competency committee, or sometimes called an entrustment committee, that receives and evaluates that request and draws on the information from a portfolio. And if they decide, that is justified given all the data that we have, then they can take that summative entrustment decision. From now on, we allow you to work with only indirect supervision or only even unsupervised. And there's many factors that actually are involved in those decisions. Just this is an ad hoc situation. And just imagine this supervisor thinks about that student. Shall I trust this student to attend to this patient now? And that's an ad hoc decision. And it has many components. So I trust this student to attend to this patient now. So that's about a trainee, this student. As supervisor, I'm the supervisor, but I may be different in my evaluation than another supervisor. What is the task? What is attending to this patient? What does it actually mean? Is that a critical task or not? This patient is also part of the context. Could be a different patient, and I might not ask them to do that, or do it now. That's different during the day maybe than in a night shift or in the weekend. So there's many things that actually come into that equation. And this is just to show that there's so many things that you could think of. Well, just focus on one thing, that is the trainee features on the left upper side. So if you go to those general qualities of a trainee that are important when you consider entrustment decisions, and we've actually, if you look at the literature, and we actually have a publication that will appear really soon, probably next week or the week after. And we have found actually that what people value, what clinicians value, is capability, which is knowledge, skills, experience, awareness, and oversight specifically for that task. Integrity is truthfulness, good intentions, patient-centeredness. Reliability is to be conscientious, to be predictable, have predictable behavior, to be accountable, responsible. Humility is this person observing their own limits? Are they willing to ask for help? Are they receptive to feedback? And finally, agency is important. Is this person sufficiently self-confident? Are they proactive towards their work, their team, their safety, their personal development? If you juggle the first letters around of these 5 elements, you come to the acronym of a RICH. So think of a rich entrustment decision. So to wrap up in this last slide, justified entrustment of trainees with responsibility is the core mission of education, competency-based medical education or other education too. And the analytical competency-based education needs actually EPA's, the more holistic synthetic approach to connect with clinical practice. Why? Because EPAs break down the breadth of a license into units of practice that we can well overseen, assessed, monitored, documented, and certified. And entrustment decisions making in assessment is more than the evaluation of skill and knowledge. And a rich entrustment decision reviews the learner's agency, reliability, integrity, capability, and humility. A traditional workplace-based assessment looks back at how our learner did. Entrustment decisions, however, look forward to future competence. So I thank you for your attention.
Thank you very much.
And how do I stop share screening? Okay, here I go.
I'll just take over, Professor Cate. Yeah, I just take over. Let me see. I have a final slide. And that's actually this one. After this, I have one more. Thank you very much for the very interesting presentation, very inspiring. And I have seen that there is a lot of questions. I thought about that before. So I put some of the questions already in the timeline of the published one. Let me see. And I promised these the people who asked these questions that we're gonna answer them in the Q&A. I don't know if you can see them all, but I can read them for. Can everyone see these questions? I guess yes. The first one is when can we really say that a student is qualified in an EPA? Is there a certain number of times that an EPA has to be carried out? I think it's a question for you, Professor Olle and Cate.
Yeah, that's an excellent question. So I can tell you there's a huge variation in doing that. So for every EPA, if you are a curriculum committee or an examination committee, you have to sit down and think thoughtfully about the EPA. And as Professor Creugers also said, well, you could have EPAs that are small, that are large. I can give you an example of if you would want to make sure at the very most junior learner that you can just imagine in healthcare is measuring blood pressure. And that could be a very small EPA. I would not recommend that for any higher level. But actually, if you would say to a student, I trust you to do that because we're not going to check that blood pressure anymore. We just accept what you report back to us. You can imagine if you just see that once or twice and see that people do that very well, that could be enough. So if you are a fellow of gastroenterology, you are learning for colonoscopies. We know that people have supervised colonoscopies about 250 times before they would even consider to be allowed to do that on their own. So that's 250. So so that is huge numbers. And of course, you would not even start to consider that on an early stage. But the lesson really is that you have to, with your curriculum committee or whoever decides about that, make thoughtful thoughts about that. And there's this one thing. If you just define a number only, if you say, well, this is an EPA, and if we observe that 4 times, that will be enough. Just realize that if you, the third and the 4th time, you would find that's not adequately done, you would have to see that more often, because you cannot sign off only just because of the number. You would have to see that because, and you could say, well, we need 5 observations, but after 3 observations that were all terrific, you might even make the decision in this case, we don't need the other 2 because we now trust this person. So trust is something that combines many, many things. If people show very stable behavior, then it's more easy actually to make that entrustment decision. If they show very unstable behavior, because sometimes they're doing well and sometimes they're not doing well. I know one of my colleagues, Carrie Chen, has a very nice slide. She shows like 15 observations of one EPA of one learner. And you could say this, on average, learner A does actually a better job than learner B. But if you look at the individual observations, you can see learner B has never been below a threshold level, whereas learner A actually shows some really bad times, maybe for whatever reasons. She does terrific on some other cases, but it's unpredictable. So that makes a difference in practice. So I would recommend for EPAs just to sit down, write that up and say, this is our general benchmark for the number, but then for the learners in practice, make a deliberate choice per learner or 2. And just also say to the learner, we're not guaranteeing that 4 will be enough. It might need 5, and sometimes maybe 3.
Okay. Thank you very much, Mr. Cate. I think it's a clear answer, although it doesn't make it really easier, of course. But I don't think, and that's the next question, I don't think EPAs are easy, is it? The next question is, does it cost a lot of change and effort by the staff instead of a traditional EPA, a traditional curriculum or an EPA-based curriculum? Is there a big difference?
So what I can tell you is that usually changing a curriculum in medicine, it takes a lot of effort anyway. But what we found in practice that if you start talking with your clinicians about EPAs, what are the things that are important? We find usually that clinicians understand that very well. They can think more easily in units of practice like EPAs than in more theoretical scaling of competencies and do that. I can tell you that just yesterday I had another conversation with a colleague in Pennsylvania, and he said, since we're using EPAs instead of the more focus on EPAs than on the milestones that are in the ACGME framework, the clinicians can much easier do that. Now, what is important, and that's the caveat, in using a skill that is focused on entrustment, that is something that people have to really understand, because that's not a habit that people have. Usually people say it's easy to look at someone and just say, did they make any mistakes? No, they didn't, so I can give a high score, they didn't make a mistake. But the question really is, and that is what the training requires for faculty development, is that you want people to think about more deeply about that trainee. Is this trainee ready to decrease your supervision? Which is a different question that they make no mistakes now. Mm-hmm. So I would say there's two sides of that coin. So working with EPAs is pretty intuitive, and people like that. And most people have no difficulty to move in a curriculum using that. Using a skill that draws on entrustment decision making that requires effort, but people understand it, but it's a different view on assessment.
Yeah, okay. Thank you very much. We have the last question because our time is almost up, and but this question I want to park for just a few seconds, because I would like to go to Mr. Professor Creugers. Maybe can you tell something about the change in your curriculum from, let's say, the old school curriculum to your EPA? Was it a complex process?
To turn my...
Yeah.
Well, as Professor Cate said, changing a curriculum is always a huge task, a huge and complex thing, and so you have to prepare that very well. And if you go to introducing something like EPAs, you have to inform the people and also find out that the people stay behind using that. And in the beginning, it needs also a lot of, let's say, talking between the members of the group, because we also have to learn how to work with the EPAs. That's a very important thing. What we did with our curriculum change for the master is we changed 3 years at one time. So it was a huge operation, and but there was also no escape anymore. And what is important is that we supported and supervised all our teachers in performing their job in using EPAs. Okay. So yes, not easy, but very much rewarding.
Not easy, but doable.
Not easy, doable, and rewarding.
Okay, yeah, thank you. It's a good summary. Thank you very much. And for the last question, I go back to Professor Cate. Isn't it getting very subjective? And you know, we were in China with a project where they wanted to use EPAs, and they wanted to use the feedback as and students who could give themselves scores, and they said that's not going to work in China because people are cheating all the time. So and that was China, but here the question is based on trust, subjective. How is that, Professor Cate?
Yeah, that's also a very good question. I can talk about half an hour about that. I published a paper in Academic Medicine last year on subjectivity, the power of subjectivity in workplace-based assessment. And maybe one lesson from that is we can work with scores that look like, because they're on a scoring form, and you could suggest that as very objective because everybody has the same scoring form and you have to score that. But you have to realize that the important decisions based actually from your observations, many things you cannot actually put on that score. So when we suggest that we have very objective scoring and assessment approaches, what we're losing is the very rich impressions you have. If you know a learner very well, you know a learner in many respects. And I tried on a few of these slides, I tried to summarize all these elements. They are so important, but you lose all that information if you use very simple scores. Now, I agree with you that it will not be easy to suggest to the outside world that these entrustment decisions are very important if you cannot document that well. So one of the things that is important is that, as I said, ad hoc decisions can maybe just by individual teachers. The important summative entrustment decisions must be taken by a team, must be based on as much information as you can get. Some people call that programmatic assessment, with combining multiple data points to come to a decision, and also as a team. And if you are a team, then if your decision to graduate a student because you have seen that they've done well, and that would be challenged by a jury for whatever reason, and you can show that you have collectively done that because you were all convinced that this person was ready for unsupervised practice, you have a much stronger case than even if you have used a form that suggests that something is objective, but it's actually pretty reductionist approach to assessment.
Yeah. Yes. Yeah, I cannot agree less with you, but you're the expert on this, so you had the last word. But this was the last question. We could talk about this 2 hours more. We're not going to do that now, but I want to try to, maybe if we had a lot of questions, we can later have a Q&A session again. We'll let's see how that works out. For now, I only can thank you very much for your contribution to this session, to this webinar. Professor Olle and Cate, thank you very much. Professor Creugers, very much. Robert Smenk, very much. Thank you. I see in the timeline on the side that a lot of people tell us how interesting it is. So that's also nice to see. So I think this is it for now. Thank you very much again. And we hope to see you again, and we enjoyed it very much. Bye-bye all.